our next webinar in our webinar series. Today, we're going to be talking about lung cancer screening in Maine, results of a survey of primary care clinicians. Our speaker today is Dr. Neil Corson, and we are so excited to have him with us today, and glad that you can all join us as well. So just some quick housekeeping slides. Those of you that have been on webinars before with us know these, but just running through those for those that may be new. So webinar logistics for Zoom. So right now, the audio lines for non-presenters are currently muted. Please use the chat box or the Q&A function for questions or comments throughout the presentation. And if you're requesting CME for this webinar and you did not sign into Zoom through a direct link, or if you're watching with part of a group, if you could please email us here at mlcc@qualidigm.org during the presentation or immediately after, so we can track your participation and make sure you get that link for the CME credit. Next slide, please. So for CME itself, we have to have our CME disclosure. So the speaker today does not have any relevant financial relationships with the manufacturers of any commercial products and or provider of commercial services discussed in this CME activity. CME will be available for participants who have signed in, as I mentioned, to the live webinar. If there are multiple people at one computer, please type their names and email addresses into the chat box for our attendance records. And again, like I just mentioned, so we can send you that link to the CME. Once the webinar is ended by the host, you will get a pop-up on your screen that will immediately direct you to the survey. The survey will also be sent via email, and please complete the survey if you can within the next 2 weeks. You will be immediately able to download the CME certificate, which is a newer piece for us, which we're very excited about, and great for you, on the last page of the survey. Make sure after you print, however, that you go back and just hit done in the survey. That's just kind of an important piece. Please contact Danielle Ziller at the email address here if you have any questions or problems downloading the document. So today, for our learning objectives for this presentation, we hope that you walk away and be able to explain the difference between the AAFP guideline on lung cancer screening and other major organizations' guidelines. Describe the survey findings regarding guidelines endorsed and current knowledge and practices. Describe 2 of the biggest barriers in Maine primary care providers identified in this survey in the lung cancer screening process for their patients. And list 2 ideas that might help primary care clinicians who want to offer lung cancer screening to their patients who are eligible. So at this point, I'm very excited and pleased to introduce Dr. Neil Corson. He is the co-lead of the Maine Lung Cancer Coalition, as well as a physician scientist at the Center for Outcomes and Research and Evaluation at Maine Medical Center. His research experience includes work on depression in primary care, behavioral health integration, shared decision-making, and practice redesign. Dr. Corson has spent almost 20 years as a family physician and geriatrician in rural Maine, and then he returned to school and graduated from the master's program at the Center for Evaluative Clinical Sciences at Dartmouth, now the Dartmouth Institute, in 2002. So Dr. Corson, again, thank you so much for joining us today, and we're going to turn this presentation over to you.
Thank you, Jessica, and hello, everybody. I appreciate you all spending your noon hour with us, learning a little bit about lung cancer screening and about some of the preliminary results of a survey that was done over the last year. While I know many of you have been listening into these webinars and know about the Maine Lung Cancer Coalition, I'm going to start by just giving you some background. So Danielle, if you could go to the next slide, please. The first thing is the funding. The Maine Lung Cancer Coalition is a 4-year statewide grant, primarily funded by the Bristol-Myers Squibb Foundation, but with generous co-funding from the other organizations listed, the Maine Cancer Foundation, the Maine Economic Improvement Fund, and the Anthem Foundation. Next slide, please. Because the Lung Cancer Coalition is a statewide group, our partners are from all over the state. You'll see on this list healthcare organizations, advocacy organizations, state government has been an active participant in our work, and others as well. Next slide, please. And just at a high level, we have been focusing on prevention and early detection of lung cancer and helping people who are found to have early lung cancer who are found to have lung cancer, period, to get connected to treatment. Our focus on prevention is mostly about tobacco, although we've also worked on radon-related issues and radon policy. Early detection is obviously about the dissemination of lung cancer screening and helping programs to get up and running. And then our stakeholders include healthcare professionals, the general public, people who are at risk and therefore eligible for lung cancer screening, as well as policymakers, et cetera, et cetera. So we have been working for almost 4 years now across the state in these big buckets of activity. The survey of primary care clinicians is really, it's an overlapping of our work on early detection with our recognition that primary care clinicians are an important stakeholder group, and we wanted to better understand their perspective. So let's go to the next slide, talk a little bit about the survey itself. And I want to give you some background. Having been a family physician in rural Maine and having done that work for almost 20 years, it was always my assumption that preventive care and specifically cancer screening was part of the work that a primary care clinician would do. And I assumed that was true of lung cancer screening as we were first writing this grant several years ago. What we have learned is that there may be some things that are different and that the primary care community has not adopted lung cancer screening to the extent that it's involved in other cancer screening, such as breast cancer and colon cancer screening. This is also a relatively new preventive service. The recommendation from the Preventive Services Task Force only came 6 years ago. And so we may also be observing what happens normally at the beginning of this, of the dissemination of a new preventive service. So with those questions, the general concern of, is there something different about lung cancer screening? Has the practice of primary care, has the sort of the environment changed such that this new cancer screening test is not being adopted in primary care to the same extent that other cancer screening tests have been? So we were hoping to learn some things from this survey. So our general objective was to assess primary care clinician knowledge, attitudes, and practices at the current time regarding lung cancer screening using low-dose CT. We decided to partner with 3 organizations that have relationships with primary care clinicians to distribute the survey. The Maine Academy of Family Physicians, the Maine chapter of the American College of Physicians, which is an organization that general internists belong to, and the Maine Primary Care Association, which is the organization of federally qualified health centers. And so each of those organizations helped us to distribute the survey to their members. In addition, at a later time, we were approached by the leadership of the 4 family medicine residency programs in Maine, and also surveyed the residents in those 4 programs. So a total of 1,283 clinicians were surveyed. Next slide, please. We received 122 responses. That's a 10% overall response rate. That is both not unexpected and a bit disappointing, one of the things as we think about interpreting the survey results is that we need to think about how might those who completed the survey either be similar to or different from those who did not complete the survey. In other words, is this a representative sample of primary care clinicians across the state of Maine? And I would be very interested in the thoughts of the audience as we go through the results to think about what would have led somebody to be in that 10% who chose to complete the survey rather than the 90% that didn't, and would that bias the results in some way that we ought to be paying attention to? You can see the breakdown by specialty in terms of our sample. Next slide, please, Danielle. And here is a description of our participants. You can see 60% female, average age mid-40s. Most people had been in practice for 14 years on average, so most people had been in practice a fairly long time. More outpatient and inpatient work, 80% doing direct patient care. So this was not only the administrative docs. We got people who are taking care of patients, and then the average number, the mean number of people seen weekly. One of the things we want to do to look at the representativeness of the survey is to compare these demographics to the demographics of the organizations in general. That'll help us at least on these parameters to see if we've got a representative sample. Next slide, please. We also asked people what county they practice in. For some people, they practiced in more than one county. So there's more than 122 answers here. There's somewhere over 130. But it was reassuring to us that we had at least one respondent from every county in the state, obviously more in some counties than others, but we did get a statewide distribution. Next slide, please. So the first set of results I'm going to go over with you are some of the questions we asked about attitudes towards lung cancer screening. I assume, Jessica and Danielle, that if there are any questions, you'll bring them to my attention. It's okay to chat in questions as we go. I'll try to stop and address any that are clarification. We'll also have questions saved up for discussion at the end. Next slide, please, to look at some of the attitudes questions. So the first thing, before I go through the results, I want to orient you to how we're presenting the results. So each of the little colored dots is a single individual's answer. You can see that these were questions about attitude. We used a 5-point Likert scale from strongly agree to strongly disagree. So 1 is strongly disagree, 5 is strongly agree, and the other 3 numbers are in the middle. We did something that I would say I would teach people not to do. Likert scales are, you know, the 1, 2, 3, 4, 5, even though they're numbers, they are not, this is not a continuous variable. These are categories, but we average them anyway so that you see the black figure on each line, on each row, which shows the average result, the black dot, and the 95% confidence interval for that average. And while you really shouldn't do that for these kind of Likert scales, it gives you a sense so you can both see the range of results for each question, and you can see sort of where those results, where the average tends to be. Again, I'm breaking some rules. You guys can yell at me for that later. So you can see the attitudes, the questions we asked. People generally agree, but not strongly, that the evidence is strong. They generally disagree, but not strongly, that the financial costs are high and that it's a low value intervention. People generally are not worried that by screening for lung cancer, we're going to reassure people about smoking and will impact any smoking prevention and treatment approaches. I think the big finding here is there's not strong feelings one way or another, and that people, while they recognize there's evidence to support lung cancer screening, at least to this question, their endorsement was moderate, not strong. Next slide, please. We then asked some questions about people's perception of the benefits and harms. So these are the perceptions of the clinicians, not what patients think about this. So again, same format that you see the individual scores, you see the average for the Likert scale, similar 5-point Likert scale, and people are most strongly convinced that screening with low-dose CT will detect lung cancer at an earlier stage than lung cancer is detected without screening. But even with that strong sense that we'll find lung cancer early, there's less strong attitude about the benefit in terms of reducing lung cancer mortality. Again, you can see that the answers tend to cluster around the middle, that people don't have strong feelings one way or another about the benefits and harms of lung cancer screening, other than recognizing that we will find lung cancer earlier. Next slide, please, which is similar discussion about the perceived barriers to their patients receiving lung cancer screening. And you can see that most of the results are, again, in that moderate range. The biggest barriers being lack of insurance coverage, lack of patient interest, which we'll talk a little bit more about as the hour goes on. Lack of time was perhaps less of a barrier than I would have thought. And the lack of facilities in the practice area was endorsed the least strongly as a barrier, even though we know, we've been working with people across the state, that there are substantial geographic parts of the state where, as of this moment, there are no hospitals offering lung cancer screening. The coastal area is the one that strikes me the most, that from Brunswick to Belfast, I'm not aware of a single hospital that's offering screening right now. Now, lack of facilities in my practice area, people can refer to Augusta, and from that part of the mid-coast that's not far, or from the southern parts of that down to Portland. But I would have thought that would have been seen as more of a barrier than it turned out to be. Barbara Wiggins says that we can tackle the insurance worry. I think it would be useful, and maybe we'll take a minute after I'm done with the presentation, just to review. My sense is that commercial insurance as well as Medicare is covering, and that if you have insurance, that shouldn't be a problem. Maybe worth circling back to that at the end. Next slide, please, Jessica. We also asked the PCPs to tell us about their confidence with skills necessary that are part of a lung cancer screening process. So tobacco treatment, discussing lung cancer risk information, which is part of the overall conducting of a shared decision-making visit, which is required by Medicare in order to pay for lung cancer screening. So again, this is a slightly different scale. It's from extremely confident at the right side to not confident at all at the left side. you can see that the answers cluster towards the confident end, that the PCPs feel confident, most confident about tobacco treatment counseling, but have a reasonable level of confidence in their ability to discuss lung cancer screening information with patients and to do the shared decision making. So this would suggest that PCPs do feel ready to take on this task. Next slide, please. So we've talked a little bit about attitudes first. Actually, maybe now is a good time. I don't know if I'm allowed to do this as a speaker, but we'll try it. Since I know Barbara Wiggin is on the call, and I know Barbara is one of the people in the state who has a lot of expertise about the billing parts of lung cancer screening. Could I ask you to just comment briefly on Maine General's experience with Medicare paying and commercial insurances paying? Actually, and we know that Maine Care is paying as well. So if that would be okay, we'll take a brief break from listening to Neil and we'll listen to Barbara for a minute. Barely. It may be that technically this is hard. Maybe the way to do it is you send the chat in and we'll read it later, Barbara. Yeah, it's a little funky. It might be hard. So thank you for that. I'll continue. And what we're going to talk now about is what people told us they're doing in terms of lung cancer screening right now. So next slide, please. Thank you. So this slide shows, we asked people to indicate which of the multiple guidelines for lung cancer screening they tend to follow. And people could indicate more than one guideline. One thing that I want to point out, so all the guidelines, with the exception of the American Academy of Family Physicians, recommend screening for high-risk populations. The U.S. Preventive Services Task Force is the one that's endorsed by far the most commonly in the state, even by family doctors. The teal bar are the family docs, the purple are the internists, the orange are the advanced practice professionals, and nurse practitioners and physician's assistants. So you can see even the family docs reported that they followed the U.S. Preventive Services Task Force more than any other. The American Academy of Family Physicians, when they reviewed the literature back in 2013 or 2014, made the decision, and this is different from all of the other groups, that at that time the evidence was not strong enough to recommend either for or against screening, and that's where they stopped. So they made no endorsement. So there is a difference in what the AAFP guidelines says now compared to all of the others. And it's interesting because there are a number of people, we've begun doing some additional analyses, who endorse both the AAFP guideline and one of the ones that says, yes, you should offer screening to high-risk individuals. We don't have those results on this presentation. I can tell you, because we've begun to look at that which guideline is endorsed does not seem to impact either current practice or attitudes. We'll have more of that to share at a later time. Next slide, please. So we then asked people, how many patients have you referred approximately for screening in the last 3 months. So here you can see that we calculated the mean, and here we really could calculate a mean because this is really a continuous variable, and that the means are basically between 5 and 10 for every group. And you can see that the range is most people are in the 0 to 10, and then you have some early adopters in each specialty who are referring more than most of their peers. So you can see, and again, when we looked at these numbers based on guideline endorsed, that doesn't make any difference. The numbers are still about the same regardless of which guideline clinician endorsed. Next slide, please. Excuse me, it's wintertime, dry air. So then we asked finally, what are you doing now? And these are how often kind of Likert scale, from almost always to never. So it's how often are you doing these things? So again, most people say they're doing this much of the time, offering screening, discussing benefits, discussing harms. What stands out here was the fourth line, how often do patients ask about lung cancer screening? And you can see most of the results are never to not very often. That number 2 is something like that. So this goes back to, there was also a question about patient interest in screening. And in a similar way, people are not asking about screening very much. This really, I think, reinforces our need to put more information out there to the general public and to the high-risk individuals who, if they knew about lung cancer screening being eligible, might be more likely to talk about it. Okay. Again, I'll just stop for a minute to see if there's any questions before we go on to the next slide. All right, well then let's go on. Next slide. So the last set of questions, we asked the survey respondents to tell us who should be doing certain pieces of the lung cancer screening process. And so let's look at the results for those. Next slide, please. So again, in this case, these were single answer questions. You had to choose who do you think should be responsible. And we asked about doing the shared decision-making visit, ordering the screening, and then following up results. And you can see that these primary care clinicians felt that the PCP, the majority felt that the PCP should do all of the lung cancer screening services that we asked about. They liked the idea, some, almost a third, liked the idea of a navigator to help with the shared decision-making counseling. Pretty much everybody, 80%, felt that the PCP should be ordering the services, so maintaining the role of sort of being in charge of ordering once the patient decided they wanted to proceed. But looking for more help once the results are in from lung cancer specialists, in other words, pulmonologists, thoracic surgeons, and or radiologists. And I would guess, especially dealing with some of the complexity of follow-up of the abnormalities found through the lung-RADS readings. So you can see that the majority of PCPs still felt that they should take responsibility, but wanted more help from specialists with this part of lung cancer screening. So next slide, please. So just in trying to draw some conclusions from what we've learned from the PCPs, some of the things that stood out. Number one was the relatively high level of confidence that PCPs have that they can do the skills necessary to do lung cancer screening, and that they support, when asked sort of who should do these various skills, they support an active role for PCPs. And that survey respondents do recognize some value to detecting lung cancer early, but even in the face of the initial study, which showed a significant decrease in lung cancer mortality, people are not yet fully convinced about that. And I think this also suggests that now that there's additional evidence out there, that we need to get that evidence out to the PCPs to a greater extent than we have so far. I was telling Jessica and Danielle as we were preparing for this webinar today that I had an unexpected snow day at home, as I suspect some others of you did yesterday. And one of the things I did was I sorted through a box of papers that had been sitting in my office for 3 years. Again, I suspect others have had this experience, and figured that I would find nothing of use in a box that had sat in my office for 3 years. But I happened upon a paper that is 25 years old, written by a gentleman named Everett Rogers. Some of you may recognize that name because Dr. Rogers wrote the classic book, Diffusion of Innovation. This is where the idea of innovators, early adopters, late adopters, et cetera, that's where all of this came from. And he wrote this article. It was in the Joint Commission Journal of Quality Improvement in 1995, talking about how what he learned about diffusion of innovations applies to healthcare guidelines. And there were a couple of interesting things. One is that innovations spread more slowly when they're more complex. And I think all of us who have worked on lung cancer screening and have looked at the rules realize it's much more complicated to order lung cancer screening compared to ordering breast cancer, colon cancer screening as the other examples that we do a lot of in primary care. Part of it is there's more rules, there's more boxes that you have to check off. You have the required shared decision-making visit, which is important but is an extra step. And so it is a more complicated screening test to implement, and that probably is one of the reasons that it may be moving slowly. Although I think it's important for us to recognize that we're only 6 years into this, and on average, people know this as well. New innovations often take as much as 17 years to be implemented. I think the other thing that's important in Rogers' work is the way to increase spread of a new intervention is to lean on the early adopters, and in particular, a particular subset of early adopters that are often referred to as opinion leaders. So in all of your organizations, there are people who may not have a formal leadership role, but everybody knows they're the people that everybody else watches to see, have they taken this new thing on? Because if they're going to try it and they find that it works, people follow their lead. So identifying the opinion leaders in your organization, if you're trying to spread lung cancer screening, figuring out how they feel about this intervention, and and using them in the way that organizations often do to be the person to try the new intervention and then talk it up among their colleagues is one way to spread. There may also be some of your opinion leaders who are going to be in the laggard, sort of the last to adopt group with lung cancer screening. They can also be useful to you because those are the people who are pointing out the problems with this new idea. And if you can understand their perception of what the problems are, hopefully you can figure out solutions to those problems and turn one of your laggards into an early adopter. They become a very strong supporter and can really be influential with their colleagues. So that's another approach for you to consider. So final slide. So I want to acknowledge my colleague Paul Hahn, the lead for the Maine Lung Cancer Coalition, the person who did the majority of putting the survey together. Susan Leeds, as the research coordinator, was the person who got the surveys out and got our data back. Jacqueline Janis has done a wonderful job of creating the slides that I just shared with you. And we really want to thank the organizations that helped us to distribute the survey and encourage their membership to respond. Those are all the organizations that I mentioned earlier. And just to highlight that the family medicine residencies now have their official sort of formal research network, which means they're looking for other projects to get residents involved in. So that's an overview of the results of the survey. There's lots more in there that we'll be sharing as time goes on, and happy for questions and discussion. I do want to go back because Barbara Wiggin was kind enough to type in some answers to the questions about insurance coverage. So let me just tell you what she said, and then we'll open it up to question and answer. So the Affordable Care Act, which is officially known as the Patient Protection and Affordable Care Act, requires that commercial insurances pay for preventive services that are endorsed by the U.S. Preventive Services Task Force at an A or B level. Those are high levels of evidence that this is beneficial. Lung cancer screening gets a B. And what that means is not only do they have to be covered, they have to be covered without any patient copay or deductible. So for commercial insurances that are required to do so by the Affordable Care Act, they are covering with no copay. Some self-funded plans can get exempted from that. I don't know the details. Maine Care is now paying for lung cancer screening. That was an administrative change that happened last year. And as you know, Medicare is paying for it as well. I think at some future time we might want to talk about the amounts paid for the shared decision making and for the scan itself. Barbara, I don't know if your audio is any better, whether you would add anything or jump in with any other additional comments. I see a question about the LungRad recommendations for small nodules from Scott Hansen. So the question, I'll read the question: have the LungRad recommendations for small nodules been validated in terms of frequency of follow-up scans? Seems excessive for small stable nodules. So Scott, thank you for asking that question. There have been some changes in the lung-rad recommendations since the low-dose CT screening started. As I think a lot of you know, part of the requirement by Medicare is to report to a registry maintained by the American College of Radiology. So they've been looking at the results of the scans that are being paid for by Medicare, and the original cutoff to call something abnormal and begin to follow up to look specifically at a nodule used to be 4-millimeter nodules. And what has been found in looking at the registry over the years is those nodules do not seem to be problematic, so they've adjusted. So now, rather than a lung-RADS 2 starting with a 4-millimeter nodule, it starts with a 6-millimeter. The result, the impact on false positive rate, it's probably dropped the false positive rate from about 350 out of 1,000 to about 250 out of 1,000. Still high, but better. And this process of using the registry to refine eligibility criteria and to refine the follow-up plans will continue. That's one of the reasons that reporting to and maintaining that registry is important. So I will turn it back to Jessica to help me with questions and discussion.
Sounds great. Thank you so much, Dr. Corson. Terrific presentation as always. And it's really great to see, I think for everybody to get that landscape and that view of what's happening in Maine. I think that, one of the things that we see in this work is about lack of time. And we hear that, but, in the survey that was around a 3. And I think that was a little bit of a surprise, I think, in looking at those results myself with the work that we're doing with ECHO and things like that. So, I don't know if there's some certain questions, I know that we have clinicians on this panel that are listening to us right now. So I don't know if there's some certain feedback that you'd like to get from that, but we could also, talk to them about what maybe some of the barriers that they're seeing within, those work flows around lung cancer screening in their practices.
I would be very interested to hear from people on the call, whether you completed the survey or not, sort of your reaction to whether it reflects the reality where you are. I would be interested in anybody's thoughts, especially those of you who might have completed the survey, on what would have motivated somebody to do so or not. Help us begin to think about any biases in who responded and who didn't. So, and I'm happy to answer any questions you may have about the results. So. We're ready. Operators are waiting.
Don't be shy, everyone. I guess one of the other questions we could ask too, Neil, is one of the things to take away is that the low number of patients that asked about lung cancer screening. I think that was a big takeaway for me in this presentation. And I think opening this up to everyone, is this what you're also seeing? Are you seeing people informed? I think that's a big piece of this, is really raising the awareness that lung cancer screening is available. And, in our role of primary care providers, to use this time when we see patients as education. And so just if anybody has, is using any type of handouts or, has anything in their process to help with that education piece, we'd like to share as well.
Well, we heard on the ECHO call yesterday, and it's interesting the way these two things lined up one day after the next. In terms of reaching out to eligible people, it sounds like a number of the hospitals on the echo are using some sort of patient information. Several talked about posters in exam rooms to get the word out about eligibility. We also know from some of our qualitative research in the state in more rural communities that there's two issues over and above insurance coverage and transportation that we heard a lot about from the rural folks who would be eligible for this. One was a fatalism that they thought they'd been, given that they'd been smoking most of their adult lives, that they were going to get lung cancer no matter what they did, and that there wasn't much they could do about it. And the other is the stigma issue, the sense that this is a cancer that if you got it because of a habit that you didn't break, we recognize the addictive properties of tobacco, but people still see it as a personal failing. And so talking about being screened for a cancer that you feel like you caused yourself, it may be that may be one of the other barriers. But I'd be interested in what others' experiences and if anybody is having success in getting patients talking about this and thinking about it, we'd also want to learn from what you're doing well. So there is a question from Tammy Kelly. Did the program post information on results where interventions saved lives to encourage screening participation? That interesting, because that came up. I remember Jessica talking about sort of using people's personal stories. I suspect every hospital that does screening will find some stage 1 and stage 2 cancers and save people's lives. I mean, that's, it makes it sound, well, it is a big deal because these people, if they did not have screening, these cancers might continue to grow and become stage 3 or stage 4, in which case the mortality rate is very high. So those local stories, if people are willing to have their stories told, are one way to get people's attention.
Yeah, and I think I would add to that, Neil, too, one of the things that we also were talking about is, one of the faculty is a nurse practitioner with the thoracic team, and, just talking to that patient, where this they found this lung cancer screening at a treatable stage. And just that voice can be incredibly impactful. A couple of the hospitals were also talking about how they use their mammography rates and compare, and using data, their own data, to kind of give that information back to providers. And they have found that to be very successful too. We all know that data really talks, but at the same time, if it's your own data, it's that much more impactful. So they were actually looking at their own, and correct me if I'm wrong here, Neil, they were looking at their own cancer registries, correct? And they were pulling
Yes.
from that, looking at that, and then pulling their mammography rates as well. And they were finding that incredibly impactful in talking to providers. And they were going on site, like going to the practices and, kind of having some nice conversations with the providers there too. So that was very effective, piece too.
Right. It was essentially showing that in a well-established screening program for breast cancer, most of the cancers found were early stage and more easily treated, demonstrating that at this point, because lung cancer screening had not been as well established, more of the cancers were still later stage. And so I think it was that contrast that they were talking to the PCPs about.
Mm-hmm. Yeah, and they found that very effective. We do have another question here, Neil, from Elizabeth.
Okay.
It said, I answered questionnaire in order to continue to learn how effectively to get the LDCT performed without having to refer Maine Care patients to pulmonology first. At this time, can I refer Maine Care, not Medicare, patients for low-dose CT without having to have them see a pulmonary first? I work in Cumberland County.
So part of the, I can't always answer these questions because these are based on the requirements of the program, and we're not responsible for the program. So I think that's a question for whichever hospital you tend to refer to. There's the issue of closed or open, centralized or decentralized programs. And I think most places in the state you can, as long as you do document all of the things you need to document for low-dose CT scanning in terms of the shared decision-making visit, the tobacco treatment counseling that you've reviewed with them, the eligibility, and the fact that it's an annual, not a one-time exam. I believe in many hospitals you can order, but I can't speak for any given hospital. I noticed you added a question that the shared decision-making requirement is different. It's not a requirement for other cancer screenings. You are absolutely right. The idea of Medicare requiring shared decision-making is a new one. This is the first cancer screening test that has required it. There are a couple of other procedures that have to do, for instance, with certain treatments for atrial fibrillation that they now also require shared decision-making. There's some talk that it may be required for joint replacement surgeries in the future. I think it's a mixed blessing at this point in terms of requiring it, because I'm not sure that we all yet know what the it is that's required. But I think this kind of requirement we are likely to see more of rather than less of from insurers. Tammy Kelly also asked a question about vaping. I was going to talk about the eligibility requirements because I think it's important for us to all recognize that right now eligibility for lung cancer screening is based sort of on population level criteria, which have to do with age and how much tobacco use, personal tobacco use you've had, actually cigarette smoking. Whereas we know there are other risk factors. Secondhand smoke is one, radon is another. We know there are lung cancers that younger people are getting due to genetic modifications. We're not able to quantify things like secondhand smoke and radon, which makes it really hard to know who's at risk based on exposure because we don't know how much exposure they've had. So I think we eventually will need to personalize the criteria for being high risk. We just don't have the ability to do that yet. So I absolutely agree. There's people who are high risk for lung cancer that are not eligible for screening, and we would do a better job. The screening would be more effective if we could target those people and screen them too. So thanks for all of those questions. Barbara's question about funds for outreach. We are doing some of that, and we're partnering well with the state and with the state cancer plan. I think we will see more of that over time, and some of that is already being done. So again, thanks to everybody for all the questions. I'm gonna let you take over, Jessica. I suspect you need to shut us down.
No, we're doing okay. We do have time for probably one more question at this point. It's about 5 of.
Okay.
Excuse me. So if anyone has one more question that they'd like to ask, certainly if we get more than one question, typically what we'll do is we'll, send that out when we send out, the slide deck, or if anyone has any specific questions, we can always answer that and send that back out to you. But we do have time for one more question, one or two, if anyone has any more they'd like to ask. All right, I think looks like we're all set at this point. It's about 4 minutes of. So the next slide, Danielle, just in wrapping up, looking at, the contact information again. Dr. Corson, thank you so much for being here today. Thank you to everyone joining us. We really appreciate the gift of your time. We know how precious it is, and really, are so glad that you could join us today and be part of this webinar. Dr. Corson, again, thank you again for putting together this presentation, joining us today. We so appreciate your time as well and expertise in this field. Here's our contact information. And I'm Jessica Reed here at Quality. I'm Danielle Zillows, our program manager. And again, we're happy to, if you get off this call and you think of things or have questions or looking for resources, that's part of our job and part of what we're doing under the Maine Lung Cancer Coalition. So we encourage you to go to the website. We encourage you to, again, reach out to us. If we can help in any way, we're happy to do so. So again, thank you all for joining us today. And Neil, do you have any final words? And then I think we'll wrap up.
Final words are, I'd be happy to answer more questions as they come up. I'd love to have your feedback on the survey and the results that you heard. And thanks to all of you for spending your lunchtime with us.
Thank you, everyone. Have a wonderful day. Stay warm. Winter's coming, or here. Thank you all. Take care.
Bye-bye.
Bye now.